I think one of the pieces that's an important take-home is that in any clinical trial, there are patient preferences that are there. Oftentimes, they actually go unmeasured, though. And in this trial, it's providing systematic randomized data that says that patient preferences make a difference.
That's Dr. Lori Zollner from the University of Washington, who will talk about her research giving patients a choice of treatment options for post-traumatic stress disorder. Her work appears in the April 2019 issue of the American Journal of Psychiatry. I'm Michael Roy, Executive Editor of the American Journal of Psychiatry, and this is AJP Audio. Dr. Lori Zollner is the lead author of an article in the April issue. Her article is titled Doubly Randomized Preference Trial of Prolonged Exposure versus Sertraline for Treatment of PTSD. Dr. Zollner is a professor in the Department of Psychology at the University of Washington, where she is also director of the Center for Anxiety and Traumatic Stress. Her research and clinical work focus on the prevention and treatment of chronic post-traumatic stress disorder. She has published widely on PTSD and on its treatment using cognitive behavioral therapy. She's also led workshops for practitioners on treating PTSD. Hi, Dr. Zollner, and welcome to the podcast.
Thank you. Glad to be here.
Now, your study used what's called a doubly randomized preference trial. This kind of study let you evaluate the effects of choosing a treatment and determining the effectiveness of a treatment. Here, your team wanted to compare outcomes between a selective serotonin reuptake inhibitor, sertraline, and a form of cognitive behavioral therapy. So first, could you talk about why you and your co-authors decided to study this issue?
Yes. It's really interesting that in the field of PTSD, when we embarked on this study, there were no head-to-head trials of a cognitive behavioral therapy and a selective serotonin reuptake inhibitor. So the field of PTSD, while you'd think it is advanced, there hadn't been a randomized control trial that actually looked at comparing a CBT to an SSRI. And when we're thinking about different kinds of treatment, prolonged exposure is a type of cognitive behavioral therapy, and so that was what was chosen to compare to sertraline. The other thing that's really interesting about it is that these are very different treatment options for a trauma survivor. One of them involves having to approach the trauma memory and to talk to a therapist about what happened, and to approach reminders of what happened as well. The other one is coming in and meeting with a psychiatrist and having a medication dosage adjust periodically over time, looking for side effects. And those two options are very, very different treatment options for people. And so it makes sense to think that there would actually potentially be preference effects, that patients would have preferences of whether or not they wanted to go in and talk about what happened or whether or not they wanted to take a medication. And so a doubly randomized preference trial is just that. First off, patients are randomized to whether or not they get their choice of treatment, and if they are not given their choice of treatment, they're re-randomized to either prolonged exposure or sertraline. And this kind of design lets us actually systematically look at whether or not there's a preference effect.
Right. Now, as you said, your study offered prolonged exposure as a form of psychotherapy as a treatment option. Could you tell us about what this type of therapy involves?
Yes, it's a trauma-focused cognitive behavioral therapy. So what that means is you bring the trauma into the room. You talk about what happened. It's one of the cognitive behavioral therapies for PTSD that has received some of the strongest empirical support. There are multiple randomized controlled trials at this point in time comparing this therapy across a variety of trauma populations, so sexual assault survivors, veterans, other war and refugee trauma, and also several good meta-analyses that argue that it is one of the better psychotherapies out there for PTSD. What the treatment actually looks like is it has multiple components, and one of the components is psychoeducation, talking about what's normal, what's to be expected after trauma exposure. And what we believe to be the main treatment components that are the mechanisms of action involve approaching trauma-related reminders. And so it involves in vivo exposure. That just means in-life exposure to safe but avoided trauma reminders. So oftentimes, for somebody, for example, who's been through a sexual assault, it might be going into crowded places or going to a place where there's lots of men. And so we would set up a hierarchy with them or a series of steps to help them approach situations that are safe, that are not overtly dangerous, but they've been avoiding because of the trauma. And then the other component of the treatment is what's called imaginal exposure, and that is approaching the trauma memory itself. And for a lot of trauma survivors, that really is one of the pieces that they would prefer not to think about it, not to deal with it, and to not let their minds go back into the memory. But what we know is that for a lot of people, that's unfinished business. And some of the re-experiencing that they're having and some of the avoidance that they have is all because of not really having an opportunity to work through and process the memory. And so we have people go back and talk about what happened and revisit the memory repeatedly over time. And what we think really is going on is two things. One is it addresses this avoidance that I was talking about, and it also helps shift unhelpful negative beliefs that somebody has developed after a trauma, about beliefs about themselves, beliefs about other people, beliefs about the world. And so the targets really are about approaching the things in somebody's life that has shifted or changed because of the trauma and helping them go back and reclaim pieces of their life that they want to move forward with.
Okay, so well, let's get to the results of your study. What did you and your co-authors find?
Great. The first thing we found is that prolonged exposure was preferred over sertraline. So when you're giving people a preference or a choice, there was a slight preference for doing the psychotherapy over the medication. And part of that, when in other studies we've asked people, in trauma, they often talk about the role of needing to talk about it, needing to discuss what happened. And so some of that preference might be just because of a need or a desire on the patient to be able to talk more about it. So we found a preference for prolonged exposure over sertraline. And then when we looked at acute outcomes and long-term outcomes, we found that both prolonged exposure and sertraline confirmed good, solid benefits for people both in the short term and in the long term. And we followed people for about 24 months. And so we saw reductions in PTSD diagnosis, PTSD symptoms, depression, anxiety, and also improvements in functioning. So we see that both of these treatments are good options for patients with PTSD. And we did find some benefit for prolonged exposure over sertraline. The final finding that we had is that match with a treatment makes a difference, and it also conferred a benefit. So similar to a benefit that we were talking about before in terms of PTSD symptom reduction, depression, anxiety, and functioning improvement, we saw all those things as well when patients were given their preferred treatment over a treatment that they didn't prefer. And what's more to that is that this match with the preferred treatment also helped with patient adherence. So people who received their preferred treatment attended more sessions. They were more likely to do homework in psychotherapy. They were more likely to take their medications on a regular basis and more likely to get up to a therapeutic dose on sertraline as well. So we see a benefit for both of these psychotherapies, and we also see a role of patient preference in the data.
That is definitely what drew us to your study when we accepted it for publication, that it had good news that both treatment protocols were effective, but that it added in the patient preferences, adding another level of effectiveness to the treatment. So it was a very hopeful message. What other aspects of your study would you say are relevant for researchers, clinicians, and other mental health professionals?
I think one of the pieces that's an important take-home is that in any clinical trial, there are patient preferences that are there. Oftentimes, they actually go unmeasured, though. And in this trial, it's providing systematic randomized data that says that patient preferences make a difference. And What I would say as well is that we don't think about patient preference as a one-time thing, but actually much more of a dynamic process, that patients and their preferences shift from the time that they call in to when they hear about what options are available, and actually as they are going forward through therapy as well, or through medication trial. And so I think some of the take-homes for folks are to be comfortable with having good dialogues with their patients about what they prefer and why they prefer it, and then helping match those preferences and not thinking that it's a one-time deal.
Indeed. And what's next for you in your research?
Well, one of our big questions that we weren't able to do in this doubly randomized preference trial was actually look at the role of combined sertraline and prolonged exposure. Doubly randomized preference trials are hard because you actually have to power for the cell that has the least preference, if that makes any sense. And so it wasn't feasible for us to include 2 additional cells that included preference for a combined treatment and then non-preference, but randomization to all of the different options. So the next study that we have done is looking at comparing prolonged exposure and prolonged exposure plus sertraline in a doubly randomized preference trial. So we will be able to, hopefully in a few years, talk about what differences there are in terms of preference for a combined treatment versus a psychotherapy, and also be able to talk about the relative efficacy of those two as well.
Well, that all seems very hopeful. Dr. Lori Zollner, lead author of an article in our April issue on giving patients a choice of treatment for PTSD. Thank you so much for speaking with us.
Thank you. Thank you for having me.
This concludes this episode of AJP Audio. You can rate and review the podcast on iTunes, Stitcher, or wherever you listen to it. Please also visit our website, ajp.psychiatryonline.org, to check out trending articles, find CME courses, and watch videos highlighting some of our other articles. Be sure to check out another podcast from APA Publishing. From Pages to Practice reviews the latest research published in the journal Psychiatric Services. It's hosted by Dr. Lisa Dixon, editor-in-chief of the journal, along with Dr. Josh Beresin. You can find it at ps.psychiatryonline.org. You can also find it on Apple Podcasts or on the podcast page of the American Psychiatric Association's website. Next month in the podcast, we'll talk with Madhukar Trivedi from UT Southwestern Medical Center in Dallas about his article on irritability and its clinical utility in major depressive disorder. We hope you'll join us. Thank you for listening.